Good afternoon, everyone. Thanks for joining us. My name is Stephen Collins. I'm the CEO of Matter. About a month ago, actually almost exactly a month ago, we brought a panel together of physicians and nurses from across Advocate Aurora hospitals to really talk about life on the front lines. What were they seeing? What were they experiencing really on the front lines of this pandemic? We thought it would be interesting to bring the same group back a month later and talk about how things have changed. So that's what we're going to do. We have four people on the panel. The first is Dr. Kerry Mendoza. She is a physician in the emergency department at works in three of the Advocate Aurora hospitals in Illinois Masonic, Trinity, and Advocate's South Suburban location. Carrie has also been a longtime member of Matter. I've known her for a number of years. She has her own startup company, and she really helped pull this panel together both this time and last time. So really appreciate it. Welcome, Carrie. Dr. Ron Lawton is the director of emergency medicine for all of Advocate's hospitals in Illinois. He's been practicing medicine for 29 years and will bring the perspective across all of Advocate's Illinois locations. Ron, thank you for joining us. Ellen Bollino is the nursing director for both emergency medicine and critical care services at Advocate's South Suburban locations. So she brings a perspective not just from the ED, but also from the ICU. Ellen, thanks for joining us again. Appreciate it. And Dr. Ross Kalman is a physician practicing in the emergency department of Advocate's Trinity Hospital on the South Side. Thank you, Ross, for joining us. So we had all of you here. Oh, and one other note, I suppose I should say for the audience, if you submit questions through the chat function, I will see those and weave those into the conversation. So ask away using the chat function. So I'll just kick it off and ask Carrie. I'll start with you. We had you here or on, whatever the right word is, a month ago, and you described kind of what your life was like, what a day in the ER looked like. How have things changed?
Well, first of all, thanks, Steve, for organizing this and making it happen, and all your Matter team and my colleagues for agreeing to participate and provide an update. I think overall the biggest thing is that we've had a decrease in volume of cases and a decrease in the really sick patients. So I think in terms of our daily life in the ER, it's much less stressful than it was at the beginning of the process. And as we mentioned before, the emergency department had done a great job really getting organized very quickly in terms of triaging, organizing the ER to keep the COVID patients in, certain areas, and how we dealt with the waiting room. And I think all of that has paid dividends through this time where now that we're on the other side of the slope, at least for this first big upsurge, that, we feel, a sense of calm and organization in the ER and safety as well.
It's good. I remember, pretty clearly the takeaway from from the first time we were together was not that it was a bunch of chaos and people like struggling in hallways, but it sounds like it was pretty intense, and glad to hear that things are calming down. Ron, is that you have a view across the portfolio of Advocates Illinois hospitals? Are you seeing any differences from one hospital to another, or is it pretty consistent, similar to what Carrie said?
Yeah, thanks, Steve. It's actually pretty remarkable how consistent the story is across all of our emergency departments. they're seeing the same kind of volumes of both COVID and non-COVID types of patients within their patient populations. And as Kerry said, there's a lot of things that have not changed in the last month. As long as we keep seeing COVID in the community, there's a lot of things that we're going to continue to do, which includes screening patients at the front door, universal masking of all of the patients that come in, our staff wearing the PPE to protect themselves and also to protect the patients, and enhance cleaning of the surfaces and the areas where patients are in contact. And these measures are all part of our effort to make sure that both our patients and our team members are safe. And as Kerry said, beyond that, there have been changes. We are more comfortable with our supplies of PPE. We are feeling more optimistic about the trajectory of the prevalence of COVID, and along with the rest of the world, we're getting a better understanding of the disease itself and how to treat it and how to address it. So overall, it's a better picture than it was a month ago for sure.
That's good to hear. Ellen or Ross, do you have any different perspective to add to that?
No, I agree. We're seeing we've had less COVID patients, and definitely it's a new way of living in the hospital and in the emergency department.
Yeah, thanks again, Steve, for having me. From my perspective, I think we've almost adjusted and adapted to this new normal. There's kind of been a normalization of how we operate on a day-to-day basis, as Ron and Kerry mentioned. Universal masking, people are triaged and immediately the front door. We know the questions to ask to screen for COVID. And then from my point of view, kind of every patient, we're gearing up as if every patient was a COVID patient. There's just been a new, I keep saying the word normalization, but we've just adapted to a new way of practicing medicine in the emergency department.
And how, so Russ, say a little more about that. Then is the new normal, which is potentially the normal for a while. What are the, obviously there's the PPE and the masks, Ron, like you spoke about. Are there technologies that are being used now that weren't before in the emergency department? Are there other sort of major changes in workflow and process that are notable and that are likely to continue for the foreseeable future?
Yeah, I think definitely lots of new technologies, with all these different modalities of testing, rapid testing, antigen, antibody testing. That's all kind of new stuff being explored. We're constantly trying out new medications. As data becomes available and research becomes available, we're trying different therapeutic modalities. Some are working, some are not working, some have no benefit. And absolutely, I think the big point is that this is not ending anytime soon. And all the models I've seen, there's going to be, different courses of how this might, go. But this disease is not going away anytime soon. So I think all these changes we're making are here to stay, at least for the foreseeable future.
What about your last time we spoke, Ellen? Maybe I'll direct it to you. It didn't sound like a significant number of your colleagues had developed COVID-19. How has that changed, if at all, in the last month?
At my particular site, the emergency department has one of the lowest incidences of team members testing positive for COVID. When we've seen our numbers come down to about 25% of what they were at the peak, with team members who were either having symptoms or on symptom watch because maybe that they were in contact with someone that was positive. So we've seen a significant improvement in that as well.
Okay.
Yeah, and I was just going to jump in, Steve, on that because I mostly go down to South Suburban where Ellen is, has her supervisory role, and we actually had some of the highest caseload in the state, I believe, and I think we were like number 2 in the advocate system, right behind Christ in terms of the number of COVID patients, and so. It is a remarkable testament, I think, to, how emergency medicine clinicians and team members really think, because once we, again, sort of got, guidance around what we needed to do in terms of the PPE and cleaning and suspicion if a patient, was what we called a PUI or patient under investigation. And that was before we had the rapid testing where we could get answers in a couple hours. So we had to do more of a clinical assumption that they were COVID before we would have results. But I think it just shows that, the team members really take everything very seriously about wearing the PPE and the cleaning and just their our environment, because you can't social distance with your colleagues in the ER. We didn't reconstruct the ER. We still kind of sit right next to each other at the workstations. But everyone just really takes it very seriously in terms of what we need to do to keep ourselves safe and the staff members. And I think that provides a lot of confidence to the patients as well. And I know you'll sort of get into, issues about the ED volumes and how we kind of, provide reassurance to our population. But when you're right there, the patients could see that, we're very careful about, putting our PPE on, coming in the room, taking it off. And so I think that's really showed in the, the few clinicians that have been, positive.
That's great. Ron, as we look to the next few weeks and a sort of quote unquote reopening of the hospitals for elective procedures and surgeries and more non-emergent conditions, from the perspective of the emergency departments, as you look across the hospitals that you oversee, how are you thinking about, quote, reopening the emergency rooms, or is there no difference at all?
Yeah, for the hospitals and for our outpatient clinics, we're kind of terming it reactivation. For the emergency departments, we've tried to apply that same term, but really for us, I'd say it's more of a de-escalation than a reactivation, because we've been at full speed ever since this began. But for the hospitals and for the outpatient clinics and other outpatient services, the reactivation is going to be more of a dial than a switch. It's not going to be all of a sudden on again. We're going to increase the capacity of those slowly over time. And we have already started with expanding our imaging and our elective procedures. The timing for that, for lifting those restrictions is really based on, it's going to be a more of a site-based determination, determined by things like, the prevalence of COVID in the area and the availability of, resources and equipment, at the site. It's just going to be, really the focus is going to be on the safety of the patients and making sure that you can provide, safe care, during the reactivation period.
And are you seeing already a significant uptick in non-COVID patients coming into the ED, and how has that evolved over the last few weeks?
Yeah. So before you're asking about, looking across the whole horizon of our emergency departments, I asked this very question to all of the ED chairs yesterday, about, are they seeing an increase in their non-COVID patients? And pretty much across the board, it was a slight increase, but not near the numbers where we were before COVID came, and before the lockdown. So we are seeing a slow uptick in the non-COVID patients, but it is slow, and our volumes are still down.
So that's consistent with everything we've seen across other systems also, that there's been, the volume into the emergency rooms basically went down like this of non-COVID, and then it's been largely flat and starting to tick up. So that's consistent with other conversations that we have. And I saw a paper, I think it was from Yale, the other day. It was looking at like one type of heart attack, and that they'd seen something like 40% fewer cases than what they would expect, and that across the board, they'd seen, that a lot less people were having strokes or heart attacks. But obviously that's not the case. They're still having these things, but they're not, they're not coming. Ron, maybe I'll start with you, but would love thoughts from others as well on what are the plans that you have to convince people that it's safe to come to the emergency room when they really should be going to the emergency room because they have something that's emergent and needs attention?
Yeah, Steve, that's a great question. It's a real concern. We have seen our volumes go down around 35% in our emergency departments, and that's across all acuity levels. So it's not just, the sprained ankles that stopped coming in. It's the heart attacks and strokes too. And we're seeing some patients come in, 2 to 3 days after their symptoms started of their heart attack or their stroke. And it's outside that kind of critical window that we can offer them the best treatments. And when we asked them why they waited so long, they admit that they were afraid they were going to get COVID by coming into the emergency department. So this really goes back to, our safe care promise that we're making for our patients, and doing things like, as I described, the screening for all patients and staff before they come into the hospital or to our clinics, the universal masking, the social distancing, or appropriate isolation of patients. It's the cleaning of surfaces and the staff wearing PPE. It's all those things that we're doing to ensure that we're providing the safest care possible. And so really, if a patient is having an emergency, a symptom that could be an emergency condition, no doubt, they should go to the emergency department. We will take care of them. We'll protect them from their other concerns, and give them good care, give them safe and high quality care.
I would totally agree with that. Emergency departments are still open and more than ready and capable to care than ever for emergencies. And I can't agree with Ron more in that a lot of these diseases are extremely time sensitive, such as strokes and heart attacks. And the treatment for effective therapy, there's often a very, very narrow window. And it's really, really unfortunate because people who are not coming, are at risk for developing permanent chronic disabilities, permanent heart conditions that otherwise may have been able to be avoided, had they timely presented. But yeah, so many steps and protocols are in place to make things safe. And now is probably safer than ever as we understand a little bit more about the disease and how to protect ourselves and our patients.
I echo what they're saying about certainly, making sure that our communities feel comfortable with knowing that coming to the hospital for the conditions, especially that are time sensitive, that we now have perfected treatments like stroke, like, getting TPA in a certain time window, or getting an intervention if you're having a heart attack and you need that. But I think we also recognize that over the years, there's been like mission creep in terms of, what comes into the ER and does it necessarily need to be in the ER. So that's, I think, the conversation, that's going to in part come out of the COVID experience, because, there are issues with access to care, and some people came that didn't necessarily need to come. Again, not talking about, these acute issues that definitely need a timely treatment.
Yeah, and that will be very interesting to see how that evolves, and whether it comes back to the same level it was before. Ellen, let me ask you a different question. One of the things that has been so striking about COVID-19 is the just the myriad ways that it presents and the course of the disease through different individuals. And I remember when we were talking last time, none of you really had a great sense when somebody walked into the hospital, were they going to be someone who was going to decompensate and be on a ventilator and end up in critical care, or were they likely to recover relatively quickly? What have you learned about this disease and how its symptoms manifest, and what, any archetypes of people that you're seeing? Are you able to have any better sense one way or the other who's going to go on which trajectory?
The expansion of our available testing has really made a difference. So we know from the beginning, now that we have I'm not sure that last time we talked, we had the rapid test, and now that we have the rapid test, the providers at every level, whether it's the emergency department, whether it's the intensivist or primary care, infectious disease, they get to see earlier in the treatment path the patients that are positive. And so I think it's really helped the physicians kind of put those pieces together. And then on the flip side, the way that we've reorganized our workflows on the inpatient side of the hospital with grouping our rounds has also made a difference in the communication between the nurses and the providers. And so I think we've learned really quickly how to take care of these patients. I'm not a doctor. The treatments are ordered by the doctors. But last time that we talked, in the inpatient side, we had surged our ICU into the surgical area, and we were running between 24 and 26 patients a day. We were running double digits ventilators, and as of yesterday, our open ICU is at 50% capacity and less than double digits of ventilators. So definitely we're recognizing it earlier and the treatments have advanced, and that's globally. That's not just at South Sub. Our physicians are consuming information that they're getting from everywhere in order to improve the care that patients have gotten, and we definitely see a difference.
Carrie, any sense when you're encountering someone? I mean, sorry, Ellen, that's great to hear. A. B. Carrie, as you're when people present and you're examining people, do you have a better sense now? You're a month later, you've seen, I don't know how many additional cases, any better ability to predict what course the disease is going to run in different individuals?
I think so. I think when we first met, I think we were in a situation where, it was early on, and we were kind of struggling with not understanding the trajectory. Like if someone came in, how quickly could they go from like being okay or mildly hypoxic to needing to be on a ventilator? And I think that was part of what was really hard. And I think now, we really know, I think part of it is that patients are coming in when they're feeling, they've stayed at home, but they're now feeling more ill. They sort of are more educated about when to come in. And there's time to, get them organized, treat them, do the things we need to do and know that they're not going to go from basically looking okay with like basically stable vital signs or maybe some mild hypoxia to all of a sudden needing to be intubated. So I think that we've all feel like pretty comfortable with that, outside of some unusual, outliers or nursing home patients that maybe they kept there for a long time and come in, much more an acute sick situation. So I think we understand that we have time to sort of settle the patients and get things started. I think that helps a lot. And I think, we really have a handle on the main presentation of the respiratory symptoms. We also have a good handle on the GI symptoms as well. And I think, as Ellen was saying, the combination of having the rapid testing with an Advocate, which is done, it takes about 2 hours to get the results back, really helps us differentiate pretty quickly who has it and who doesn't. There's some details in there about, like, if you still have a high suspicion, maybe there's still going to be a patient under consideration and get a second test. But in the main, we sort of are able to differentiate things pretty well. And I believe that the subsequent testing really bears that out.
Yes, Steve, and I would like to echo both Ellen and Carrie's points. As Kerry was saying, we are getting more comfortable with the typical respiratory complaints or the GI complaints. But as Ellen was saying, we're expanding our testing, and we are now testing every patient that gets admitted to the hospital, regardless of COVID symptoms. And with that, though, we are finding that there are some atypical presentations for COVID. A case that I had a couple of weeks ago, a patient came in with a stroke that started the day before. He waited to come in, but his only complaint was right-sided weakness. And as I was looking at him, though, he was breathing hard. And so I asked him, I said, "Well, do you feel a little short of breath too?" He goes, "Maybe." And I asked him, "Have you had a cough?" He goes, "Maybe a little bit." And it turned out that he had COVID. And was having a stroke. And we are seeing now more in the literature that patients, particularly young patients with COVID, are having stroke events and other blood clot forming conditions like DVTs, blood clots in the legs, and things like that. So we're finding that COVID is a kind of a procoagulant, meaning that it kind of promotes blood clot formation and can lead to things like strokes and DVTs and blood clots in the lungs and things like that. So we're still seeing some unexpected presentations with this.
Got it. And Ron, talk a little bit more. Let's talk a little bit more about testing. It's been a theme of this conversation so far among all of you, the importance of having these rapid tests. And you mentioned you're testing every single person who gets admitted. Presumably, are you also testing every single person who walks into the ED? And how do you decide which test to give them? Because I guess I'm saying that because I know you have capacity constraints on the rapid tests, so maybe you could talk a little bit about that as well.
Yeah, so that's a very kind of a difficult question it varies a little bit site to site. So rapid testing is the ideal situation, but you want to make sure it's reliable and that the test is sensitive. And if you get a negative, then it means that patient really probably doesn't have COVID. And so it was very important for us to make sure that we had a rapid test that met that criteria that we could rely on. And we have that test. So we are able to perform rapid tests where the results usually come back within 2 hours. But as you can imagine, there's a lot of demand for that test. And so the supply is limited. So we use it for selective cases. We certainly use it for patients who need emergency surgery or are having a heart attack and are going to the cath lab or a woman in labor. And then we also try to test for patients who it's important for us to know otherwise for the management of their care. But other than those, most of the patients we're doing our own labs test, which takes about an hour. It takes about a day turnaround time. And so we're using those on all of the patients that get admitted to the hospital, as I said, regardless of whether they have COVID symptoms or not. And then for the patients who are being discharged, so we're not testing every patient that shows up to our emergency department, but for the ones being discharged who have symptoms, then we do have options for testing them as well. And we're expanding our testing within Advocate Aurora out to the community, and we're opening up community testing sites for outpatient testing for patients who have symptoms. So it continues to expand. It continues to get better. We're in a much better place than we were a month ago, and we'll be in a much better place in another month, I'm sure. but we still have some limitations, but I think that the processes that we have in place and the way we're doing it is very sound and it's working well right now.
Ross, when you're somebody, you're with a patient, you've got a limited number. I can't remember how many you said. It was not very many rapid tests that you can use over the course of a day. How do you decide which test to give them?
I mean, fortunately, we have some protocols, in place, and we're kind of organized about how we decide who gets which test. At this point, every patient who's being admitted is getting tested. And part of safely treating patients is separating and isolating those who are being admitted and have it, which are going to separate, kind of red zone or hot areas of the hospital versus people who don't have it. So that's helping us triage. From my perspective, we are reserving at this time the rapid tests for people who need emergent procedures, emergently going to the cath lab, a woman in labor, someone who needs to be transferred to another hospital. Psychiatric transfers are getting rapid tests. Other patients are getting tested, and those other tests, the turnaround time is continuing to get better. I think initially, a month ago when we talked, everything was being sent to the state lab and it was a 4 or 5 day turnaround time. And now the average test that's not a rapid is maybe back in 8 to 12 hours, which is still pretty good. And often we're just presuming people have it if they meet the criteria and have the symptoms, and we're treating them as such, just presuming they have it.
And are you seeing people that you presume have it and the tests come back negative, or vice versa? And with the vice versa, I think people expect, given the variance of symptoms. Are you seeing a meaningful number of people who you think that person must have it and the test comes back negative anyway?
Yeah, sometimes it really is surprising, but I think that brings back the conversation about, we really need to emphasize the quality of tests and focusing on the specificity and the sensitivity of tests. And the rapids are not as good as some of the other tests, but that's really key to focus on, like how good are the tests, so we know we're getting good information.
Got it.
And I have at times have seen patients where this is kind of happening more again with the increased testing. You can get a patient coming in, they have some mild symptoms, and they're like, I was tested at the X drive-through or the so-and-so place, and it was negative, but I'm still having symptoms. And then we test them and it's negative. I've had a few times where they tell me they were negative somewhere else and then they're positive, but they look positive. The ones that seem to have the dual negatives, don't really have dramatic symptoms. So I think, like any testing, obviously you want to know the sensitivity, specificity, but then you also want to know your pretest probability, right? If you're basically don't have symptoms or very mild symptoms, it could be something else like your allergies or some other cold, you kind of have a low pretest probability. So if you get a negative test, you kind of feel like, well, I can believe that. I think where it's difficult is when you have sort of that middle, I'm not sure, they have some strong features, but whatever, and the test is negative. So that's the mushy middle, I call it. And that's where the hospital does have certain protocols of still calling them a PUI or patient under investigation. And they might watch them for 3 days and then retest them. And I know that, also nursing home situations, and Ellen can probably speak more to that, we've had times where they're negative 2 times, but the nursing home doesn't want to take them back, and all kinds of logistical issues, or they're positive, but they don't want to take them back till some time in the future when they're negative, which we don't know. So there are some logistical problems with that. And then just the last group are the people that look like, oh my God, 100%. I've seen hundreds of COVID cases. That person has COVID and the test comes back positive. So it makes sense. But it's that middle that's hard, where operationally we've had to evolve to be very efficient. And again, I think Ellen probably could speak more to that because she deals with those kind of issues up on the floor.
So I think it's important to note that there's a couple different manufacturers out there for tests. So what they might use at a community drive up that is not run by Advocate Aurora may be a test less specific and sensitive than the tests that we use. So when a patient comes in to South Sub and they say they've tested, say, negative or positive, oftentimes we retest because we're not sure of the integrity of the test that was used. So I think that that's important to note as well, because I know that there's been some, press about the rapid test. And not all rapid tests are created equal. And then in terms of the nursing homes, certain nursing homes have good environments for social distancing and keeping the positive patients separate, and others not so much. And so we've worked really closely from an administrative perspective, talking to them and deciding where's the safest place to take care of a patient. And so we've definitely had situations where we've been able to discharge patients even from the emergency department back to nursing homes without issue. And then we have other places where not so much. And it really just depends on what they have going on, because of course we always want the patients to be taken care of in the safest environment possible. So there's definitely has been cases of patients that have had from congregate living areas that have had to come into the hospital because it's a better environment of care for them, even if traditionally we wouldn't have kept them in pre-COVID times.
Ellen, as long as you have the microphone, another thing that has come up, or one of the sad, I guess, many sad consequences of this is the limitation of visitors to see loved ones who are in many cases in the ICU, and wondering how you've seen and dealt with that, and whether there's anything changing or anything's changed over the last month with kind of visitors and family and people in the ICU.
There's still some pretty significant restrictions on visitors in the ICU. We have Zoom set up, and we also have liaisons at the hospital who can assist family members in downloading and setting up Zoom on their end. And then we schedule meetings where they can speak to physicians and see their family members. Even if their family members may be sedated or on a ventilator, they can still talk to them, and they can talk to the nurse and things of that nature. Of course, it doesn't take the place of actually being with your family member. And some of the concerns about letting visitors come in is, we don't know their status, and if they're sick and if they've been exposed, and we have immunocompromised patients in our hospitals and things of that nature. So I do see that starting to loosen soon. I'm not sure the timeline on that, but it's definitely still something that we're struggling with.
I would just add to that, I think technology is going to play more of a key role than ever in helping, family members communicate with each other, when one of them is a patient. For example, in our ER, we installed just phones in every room, so family members can call and directly via the operator just be connected with the patient. Other hospitals, as far as I know, ours, admitted patients, there's sort of iPads on wheels that can be rolled around for Zoom sessions so families can telecommunicate. Because one of the hardest things about this crisis is that people are getting sick, being admitted to the hospital, and are alone. And that's just a whole, human component, which is just really sad and very upsetting. But I think technology is the bridge to safely make families able to, communicate with each other.
Yeah. So speaking of technology, Advocate has a hospital at home program. I'm not sure who to direct this to, so whoever would like to take this, but can you tell us a little more about, what is that program, and how is it working, and how has that evolved over the last several weeks?
Yeah. Hi, Steve. I helped develop that program, so I can speak to it. We developed two programs. One is called the Recovery at Home, and the other one is called the Home Hospital. And both are meant to allow patients to be discharged home, where they can be more comfortable but be closely watched. And so for the Recovery at Home program, that's more designed for patients who present to the emergency department and they don't really need any specific treatment at the time. They don't meet criteria for admission to the hospital, but we have concerns that they might worsen, for whatever reason. Maybe their oxygen count's just a little bit low, or maybe they have risk factors. So we enroll them in the Recovery at Home program. We give them a device that allows them to measure their oxygen count or their oxygen percentage, and then arrange for daily visits, either virtually or in person. We try virtual, and if there's any kind of barriers, to that being done, then we do it in person, and that's worked well. It's allowed patients to go home and be comfortable, and it's allowed us to catch a few patients who did get worse and did need to come back to the hospital. The home hospital program is more for those patients who are stable, but they need a little bit more care. Maybe they need a little bit of oxygen. So they're given a device. It's actually a cellular device that allows for monitoring of their oxygen count, along with their blood pressure and their pulse and their temperature. And so they get they're more closely watched. And then they also get the daily visits. And we've been using that one less, because that one was more designed for when our hospitals are full and at capacity. Rather than have them spend 2 days in the emergency room waiting for a bed upstairs, let's see if we can let them go home and watch them closely and keep them safe. And so that one hasn't been used as much at this point, because we really didn't reach that critical capacity in our hospitals to warrant it. But we have been using the Recovery at Home. And as far as the future of that, I would really like to see this developed post-COVID to cover other conditions where a patient doesn't really fully need all the resources of a hospital, but needs a little closer watch. And so to allow them to go home, be comfortable, but be watched and get again safe, good care. So we'll see where it goes. I'm excited about that one.
And is that, Ron, is that a device that you got off the shelf? Is it a collection of devices? How are you and are you, for the people who've been on that, has it been there any barriers to people using this stuff correctly and getting accurate and the volume of data that you're looking for from people when they're not being directly supervised in the hospital?
Yeah, so I have to admit, I'm not sure of the supplier of the device. It is a cellular device, so it doesn't depend on the patient having Wi-Fi at their home. And so on the first visit, actually at discharge, they send a person out to the home to do that first visit when they get discharged and set up the equipment and make sure that it's working well. I have not heard of anybody having difficulty sending over the data or being monitored. But again, we have used that program on a very limited basis, but I have not heard of any issues.
Got it. So last time we talked, Ross, one of the things that came up were kind of shortages of equipment, whether it's PPE or other equipment, just to check in whether you're still experiencing, and I should clarify, we were not hearing from any of you the kind of disasters that we were reading about in other places, but there were still constraints on the availability of supplies that you really needed. Where are we today?
I think things have honestly much improved. We're still using things cautiously and trying to conserve, not be wasteful. But I have no concern that every day I can get the supplies I need and, to protect myself and to protect other patients. So from a PPE standpoint, things have much improved. And I know Advocate has long logistical supply chains, and people have been working very hard to ensure that we have what we need. Nationally, there has been shortages of other things, some medications, as evidence goes up and down for different medications. You may have heard of like remdesivir, a novel antiviral drug. I think I heard that the company who manufactures in California only has maybe 1.5 million doses for the whole country or something like that. So, certain medications that we're using more are nationally less available, especially, when patients are intubated. Different sedation medications, have occasionally become in short supply. But I think as this disease continues to be with us, supply chains are doing overall a very good job at keeping us supplied with what we need. So I've had no problems.
Great. I'm looking at the questions that have come in through the chat, and would just let everyone know who's listening, if you have a question you'd like to ask to the panelists, drop it into the chat, and I'll see those. So Kerry, one of the questions that came in kind of touches on something I think you mentioned. It could have been somebody else, but and that has to do with the difference. You had mentioned that one of the hospitals you work at had the, I think, second highest number of cases in the state. And there's quite a variety, or quite a variability of, from one hospital to another, of the volume of cases. And the questioner's asking, is that incidental or not? And how does that relate to the demographics of the people in those areas, and whatever underlying conditions, either health-wise or otherwise, that is creating the different volumes of cases from one hospital to another?
Yeah, so like I said, I primarily now go down to South Suburban, which is, still in Cook County, but it's on the south side, down by like Homewood, Flossmoor. And then I know Christ in our system has been #1, and that's more to sort of a little bit northwest of where we're at. So I think in terms of our typical patient population down there in the neighborhood, some of the issues just relate to the comorbidities that exist in that population that are pre-COVID. So some of the things we know now that are related to, folks getting sicker and perhaps having a poor outcome. So obesity, high blood pressure, diabetes for sure. We've got a lot of folks on dialysis. Although I have to say that population seems to actually have been okay. And I don't know if it's because the dialysis centers were very aggressive up front about their PPE and all that kind of stuff. But in general, I think it's just the comorbidities that exist in that population have made it harder. I think that when the patients get really sick, they've already got a bunch of challenges in their body that I think make it, difficult. I think also what I've seen in terms of, when I always ask what patients do for work or their living situations, down there, there's more folks that work, at large warehouse fulfillment type centers. It's a meat packing plant. There's a Ford plant, delivery type jobs. I've taken care of some stewardesses that, were positive. So I think there's like the comorbidities, and I think probably the, types of jobs. But I think when you're looking at job situations also, I think at the beginning, there are quite a few people who maybe were, in different parts of the city, but were like business travelers for companies that I think were exposed a lot, or maybe just did more international travel for, their pleasure or for work. So, I think that there's different pockets and they're related to work and exposure. But definitely, I think the comorbidities have been, a main contributor.
Thank you. Ellen, one of the things that we also talked about last time was just the health and kind of resilience of you and all of your colleagues who are on the front lines. Can you talk about self-care and resilience and either from your perspective or what you're seeing from your colleagues and just how this pandemic continues to affect your teams, or not? Are we sort of past the point where there's anything to worry about?
I think that they've adapted in a way that it's just another day at work. I think that the sense of kind of we're all going through this together as a community and as a hospital makes a difference in terms of support. But it's just become another day at work. In the emergency department, we're not seeing quite the volumes that we were seeing pre-COVID, and we also have supplemented our staffing in order to be able to properly social distance and isolate our patients. And so we're kind of in a good place from that perspective. We have enough team members that no one's really stretched that thin, nor do they have to work a bunch of extra hours. And so I think that the morale in the emergency department, I would say right now, is pretty high. A little bit different on the critical care side, because I think that they had to see a lot of really sick patients with not the visitors like we talked about before, and so they're a little bit behind in terms of morale and resiliency, and then just making sure that those team members are taking off the time that they need and that they're providing themselves care, and that we're able to supplement their staffing from other places so that they don't feel poorly about taking days off of work.
Got it. Have any of you, again, I'm looking through the questions that people have asked, have any of you seen that kids present with that Kawasaki-like condition that we've read about, and that at least in New York sounds like they've had triple-digit number of cases?
I haven't seen any kids or young adults with COVID, nor with, obviously not, COVID with Kawasaki. And over my 20 years of practicing emergency medicine, I've had one, maybe Kawasaki, that I thought that didn't turn it out to be that. And I've always practiced in places in the community that have a mix of adults and kids. No, I haven't. Ross, have you seen?
I have not seen any kids. In general, I've seen much fewer pediatric patients in general. Kawasaki is a little bit of a difficult disease to diagnose, and honestly, pre-pandemic, we still didn't really know what caused Kawasaki. I mean, viral etiology was thought to possibly be responsible, but it's really thought to be like an autoimmune disease, and a virus might be a trigger. I've certainly read about it, but I've not seen any cases. I've not seen any cases of it.
Got it. Ron, question for you. This pandemic has been very challenging on the budgets of hospitals across the country. Advocate Aurora has been pretty public about the challenges that this is having from a financial point of view. Are the fiscal constraints having any impact on emergency departments at this point?
Yes, Steve. So we were fortunate going into this to have very strong leadership and a very kind of solid financial footing to begin with. But no doubt this is having a huge impact and is going to create new challenges for our organization. But regarding the emergency departments, honestly, I haven't seen any changes, and I'm not expecting them. We still need to make sure that our frontline staff have the resources that they need to provide care for the patients, and I don't see that changing at all. So no, I have not felt any impact in the emergency departments. I haven't seen any coming. Ask my colleagues if they have. Ross or Carrie?
You cut off there for a minute.
Oh, he was just talking. Not at all. I mean, I think, colleagues I have that are across the country work with maybe large staffing groups that have contracts to staff ERs. They've definitely had, issues of their hours being cut, and maybe benefits and things being cut. But we haven't seen that at all. I think that we have a very flexible staffing model that when we have surges and kind of holes in the schedule, that the departments are very well run, that have been managing that pre-COVID. And so even though our volumes are down, I think, to Ron's point, they communicate well with us that, we expect the volumes to be probably in that swoosh pattern, slowly go up. But, I think that they're very, fair-minded about, how to keep things going and appropriately staffed for the patients and clinicians feeling comfortable.
Yeah, I would completely agree. I definitely have colleagues across the country who have felt some financial repercussions, but within Advocate, I feel we are absolutely more than adequately staffed. And I honestly feel very fortunate compared to, I'm sure, a lot of people around the country, not just in medicine, who are really struggling financially. And I feel more safe and secure with my job and my financial position than ever. And I feel very, very fortunate. I do worry, though, outside of Advocate, how some smaller hospitals and some smaller private groups are doing. And I suspect they're struggling, some 1 or 2 hospital systems. I think they're going to face some real challenges coming out of this and looking to survive.
And Steve, I'd only add that, we're going to need to remain, fiscally responsible throughout this. And so, at this point, our volumes are down. We're not sure which direction they're going to go. There's a lot of different thoughts on that. Some feel that when the lockdown is lifted, then our volumes are going to shoot back up. There's going to be a lot of pent up demand, and we're going to see higher than normal volumes. Others are kind of what Kerry was saying about realizing that there's some conditions that maybe didn't need to go to the emergency department to begin with, and so maybe they're going to continue to stay away from the emergency department, and our volumes are going to be low. So, only time will tell. So, but, as we're going to have to keep a close eye on this and make adjustments to our staffing and to our utilization of other resources, based on where those volumes go. So, it's something that we're, even before COVID, that we had to keep track on and make sure that we were doing the right thing. And, it's going to be ever more important, as we go through the COVID and beyond.
Well, thank you, Ron. And that's a perfect way to wrap things up as we get to the top of the hour. I appreciate all of you spending an hour with us again. Last time we had this panel, I was really impressed with all of you and the way that you seem to be handling this pandemic, and was walked away from that panel feeling like slightly more optimistic than what I would read in the newspapers, and that at least on the Advocate Aurora side, the organization seems to have its act together, and these are really high quality people who are on the front lines. And I come away from this panel with exactly the same sentiment. So really appreciate you spending the time with us, and thank you to everyone who joined us this afternoon.
Thanks.
Thank you very much.